Dual diagnosis in the context I'm discussing today is a co-occurrence of mental health issues and substance abuse problems, and it's often referred to as comorbidity. Since the dawn of time, these two elements have coexisted. However, it's only been in the early 80s that a relationship was identified between the two, both in occurring together and that when it did, the outcomes for young people were much worse. Generalised Anxiety Disorder, or GAD, occurs in roughly 3% of the population and 3% of young people. Alcohol is an accessible drug, and many of the young people will present in the pre-contemplative stage, not fully aware of the problem or risk. Alcohol may be used as a self-medication for GAD. But self-medication is just a form of one of several perspectives. The medical perspective of dual diagnosis that sees a substance use disorder as a chronic and recurring illness. There's also the moralistic perspective of substance abuse being bad behaviour and emphasising punishment and control. The psychosocial risk perspective is that people, due to their situation, are vulnerable to their environment. And then there's the phenomenological perspective, which encompasses the individual's own perspective and meaning on their substance abuse. It's a person-centred approach. For young people with dual diagnosis, factors from all these areas can be at play. For example, the medical perspective may be relevant for those with strong physiological syndrome of dependence, but the social factors of psychosocial risk may also better account for the evidence. The Australian National Comorbidity Project identified young people with dual diagnosis as being at increased risk of poor treatment outcomes and social disadvantage. An Australian study into substance abusing young people found 49% fulfilled criteria for a current mood or anxiety disorder, more highly pronounced amongst female participants. A young person with generalised anxiety disorder may have it for their lifetime, but it can be managed with a combination of psychotherapy, group supports, and possibly also with medications such as SSRIs. Tranquilizers used to be used, but this could also have the potential for abuse. Some literature exists that suggests the diagnosis of GAD may show an increased experimentation with alcohol in young people. However, there's no evidence that it produces problematic use of alcohol over time. Environmental and genetic variables may account for the comorbidity between GAD and alcohol abuse disorder. Yet the co-occurrence of anxiety disorders such as GAD and alcohol use disorders are relatively common, and investigations into why this occurs are multifaceted and complex. Large-scale studies show that this comorbidity occurred about 2 or 3 times as often as would be expected by chance alone. Thus, a single model of therapeutic intervention does not adequately support the complex and multifaceted needs of young people that we may be working with. We also work in diverse environments with diverse young people, and our therapeutic practice should be able to tailor to the individual needs of our clients. When working with a young person, there's 3 areas of assets and resources to investigate to provide a resilience-based care plan. The social ecology around the young person, their access to the basics such as housing, food, income, safety, to mutual support connections if available, such as family, involvement in education or sport, and their access to various health services. The young person's personal knowledge, living skills, resourcefulness and literacy, their ability to manage themselves emotionally, their problem-solving ability and mental health, their interpersonal skills, intelligence, temperament and other attributes. And finally, the young person's concepts of themselves and the world around them, the meaning that they make in life, their self-esteem, values, attitudes and interests. All these areas need to be considered in building a strategic approach to supporting individual young people. Each young person is unique, and we have a variety of tools we can use. A resilience-based intervention has 5 domains of need to work out priority action areas: safety and the ability to respond to crisis, stability and being able to cover basic needs, participation and engagement in school or work, developmentally conducive relationships, and the ability to maintain greater control over harmful behaviours. Having an understanding of the needs of a young person is an important part of any therapeutic intervention. It is the understanding of these elements that allows us to choose the best tools to support a young person at risk or in crisis. So what kind of tools would we have in our belt that may be able to support us? The human rights framework of an ethical codes of practice underlies our interactions with young people, our considerations of culture, the importance of agency and respect in our communications, our honesty and integrity, recognition of boundaries, privacy and confidentiality, while maintaining our duty of care. We may build a better understanding of a young person with motivational interviewing, a technique that promotes movement and commitment towards change while building a rapport with a young person. It supports a young person to explore the difference between their current behaviour and any goals or wishes that they may have for the future. Cognitive behaviour therapy approaches supporting a young person to rethink problematic behaviour and unhelpful thoughts and teaches new ways of responding to situations. It approaches biased ways of thinking via the person's own logic and reasoning and is particularly relevant for clients that have suffered trauma and other bad experiences. Narrative therapy and mindfulness can be particularly effective in challenging negative personal identity, providing a new future story of direction in life, establishing a clear and preferred identity for the young person. These models are just some of the many tools a youth worker may need in approaching a resilience-based intervention. GAD and alcohol use disorder can be extremely diverse in how it presents, and a youth worker requires themselves to be flexible in responding to the needs of a young person by clearly working out the process of our person-centred approach.